Inflammation is a complex biological response of the body to harmful stimuli, such as pathogens, damaged cells, or irritants. It is a crucial part of the immune system's defense mechanism, aimed at eliminating the initial cause of cell injury, clearing out dead cells, and initiating tissue repair. Inflammation can be classified into two main types: acute and chronic. Acute inflammation is a short-term process that occurs in response to injury or infection, characterized by the rapid influx of immune cells, while chronic inflammation is a long-lasting response that can result from persistent infections or prolonged exposure to irritants. The process of inflammation begins with the recognition of harmful stimuli by immune cells, particularly macrophages and dendritic cells. These cells have pattern recognition receptors, PRRs, that detect pathogen-associated molecular patterns, PAMPs, and damage-associated molecular patterns, DAMPs. Once activated, these immune cells release various signaling molecules known as cytokines and chemokines. Cytokines are crucial for regulating the inflammatory response, while chemokines attract other immune cells to the site of injury or infection. One of the hallmark signs of inflammation is increased blood flow to the affected area, a process known as vasodilation. This is mediated by the release of vasoactive substances, such as histamine and prostaglandins, which cause blood vessels to expand. The increased blood flow results in redness and warmth, while the increased permeability of blood vessels allows proteins and immune cells to exit the bloodstream and enter the tissue. This leads to the accumulation of fluid and immune cells at the site of inflammation, causing swelling. As immune cells infiltrate the inflamed tissue, they work to eliminate pathogens and clear debris. Neutrophils are often the first responders, arriving quickly to ingest and destroy pathogens through a process called phagocytosis. After neutrophils, monocytes migrate to the site and differentiate into macrophages, which play a critical role in tissue repair and regeneration. They continue to clear debris, but also produce growth factors that promote healing and restore normal tissue architecture. While inflammation is essential for healing, it can become problematic if it becomes chronic. Chronic inflammation is associated with various diseases, including autoimmune disorders, cardiovascular diseases, and cancer. In these cases, the immune system remains activated without a clear purpose, leading to ongoing tissue damage and dysfunction. Understanding the mechanisms of inflammation is vital for medical students, as it forms the basis for developing therapeutic strategies to manage inflammatory diseases and promote effective healing. Mediators of acute inflammation are various substances involved in the inflammatory response that help to initiate, amplify, and regulate the process. These mediators can be broadly classified into two categories: chemical mediators and cellular mediators. Chemical mediators include a range of molecules such as cytokines, histamines, prostaglandins, and leukotrienes, which play essential roles in signaling and orchestrating the inflammatory response. Cellular mediators, on the other hand, involve different types of immune cells that release these chemical mediators and respond to them. One of the first mediators to act in acute inflammation is histamine, which is primarily released by mast cells and basophils in response to injury or infection. Histamine promotes vasodilation, which increases blood flow to the affected area, resulting in redness and warmth. It also increases the permeability of blood vessels, allowing plasma proteins and immune cells to leak into the surrounding tissue. This process leads to the swelling characteristic of inflammation. Histamine's rapid action is crucial for the initial phase of the inflammatory response. Cytokines are another critical group of mediators that are produced by various immune cells, including macrophages and T cells. These small proteins facilitate communication between cells and help to coordinate the inflammatory response. For instance, interleukin-1, IL-1, and tumor necrosis factor alpha, TNF-A, are key cytokines that promote inflammation by attracting more immune cells to the site of injury. They also stimulate the production of other mediators and enhance the activity of other immune cells, further amplifying the inflammatory response. Prostaglandins and leukotrienes are lipid mediators derived from cell membrane phospholipids. Prostaglandins are produced by various cells and play a role in promoting vasodilation and increasing blood vessel permeability, similar to histamine. They also contribute to pain and fever associated with inflammation. Leukotrienes, primarily produced by leukocytes, are potent mediators that attract neutrophils and eosinophils to the site of inflammation. They enhance vascular permeability and contribute to bronchoconstriction, which is significant in allergic reactions and asthma. Lastly, the complement system is a group of proteins that play a vital role in the inflammatory response. When activated, complement proteins can lead to the direct destruction of pathogens, enhance phagocytosis by opsonization, marking pathogens for destruction, and promote the release of inflammatory mediators. The complement system acts as a bridge between innate and adaptive immunity, highlighting the interconnected nature of the immune response. Understanding these mediators is essential for medical students as they form the basis for diagnosing and treating various inflammatory conditions. Toll-like receptors, TLRs, are a crucial component of the immune system that play a vital role in recognizing pathogens and initiating the immune response. They are a type of pattern recognition receptor, PRR, found on various immune cells, including macrophages, dendritic cells, and B cells. TLRs are named after the toll gene in fruit flies, which was discovered to be important for immune responses. In humans, TLRs help to identify common patterns found in pathogens such as bacteria, viruses, fungi, and parasites, allowing the immune system to respond effectively to infections. There are 10 known TLRs in humans, each with specific roles and recognition capabilities. They are primarily located on the surface of immune cells or within endosomal compartments, where they can detect extracellular and intracellular pathogens. For example, TLR4 recognizes lipopolysaccharides, LPS, a component of the outer membrane of gram-negative bacteria, while TLR3 recognizes viral double-stranded RNA. When a TLR binds to its corresponding pathogen-associated molecular pattern, PAMP, it triggers a signaling cascade that activates the immune response. Upon activation, TLRs initiate a series of intracellular signaling pathways, primarily through proteins called adapter molecules. One of the most well-known adapter proteins is MyD88, which helps propagate the signal from TLRs to the nucleus of the immune cell. This signaling cascade leads to the activation of transcription factors such as NF-κB and IRF, interferon regulatory factor, which promote the expression of various cytokines, chemokines, and other inflammatory mediators. This process enhances the recruitment of additional immune cells to the site of infection and helps orchestrate a robust immune response. Additionally, TLR activation not only stimulates the release of pro-inflammatory cytokines, but also enhances the expression of co-stimulatory molecules on antigen-presenting cells. This is crucial for bridging the innate and adaptive immune responses. By presenting antigens along with co-stimulatory signals, TLR-activated dendritic cells and macrophages enable T cells to recognize and respond to specific pathogens more effectively, leading to a more targeted and long-lasting immune response. However, while TLRs are essential for defending against infections, their dysregulation can contribute to various diseases. Overactive TLR signaling is implicated in autoimmune disorders, where the immune system mistakenly attacks the body's own tissues. Conversely, insufficient TLR activation can lead to increased susceptibility to infections. Understanding the mechanisms of TLRs and their role in the immune response is fundamental for medical students, as it provides insights into both host defense and the potential development of therapeutic interventions for infectious and autoimmune diseases. Arachidonic acid metabolites are important signaling molecules derived from arachidonic acid, a polyunsaturated fatty acid found in the cell membrane phospholipids of many cells. When tissues are injured or activated by inflammatory signals, arachidonic acid is released from membrane phospholipids, through the action of phospholipase A2. This release is a critical step in the inflammatory response, as arachidonic acid serves as a precursor for several bioactive compounds, which play vital roles in modulating inflammation, pain, and other physiological processes. Once arachidonic acid is released, it can be metabolized through two main enzymatic pathways, the cyclooxygenase, COX pathway, and the lipoxygenase, LOX pathway. The COX pathway produces prostaglandins and thromboxanes, while the LOX pathway generates leukotrienes and lipoxins. Prostaglandins are known for their roles in promoting inflammation, regulating blood flow, and inducing pain and fever. For instance, prostaglandin E2, PGE2, is particularly important in mediating fever and pain responses, making it a target for non-steroidal anti-inflammatory drugs, NSAIDs, like ibuprofen and aspirin, which inhibit COX enzymes. Thromboxanes, another product of the COX pathway, are primarily involved in platelet aggregation and vasoconstriction. Thromboxane A2, TXA2, promotes platelet activation and vasoconstriction, playing a crucial role in hemostasis and the maintenance of blood pressure. This balance between thromboxane and prostacyclin, produced by endothelial cells, is critical for normal cardiovascular function, as prostacyclin has opposing effects, promoting vasodilation and inhibiting platelet aggregation. In the LOX pathway, arachidonic acid is converted into leukotrienes and lipoxins. Leukotrienes, particularly leukotriene B4, LTB4, are potent chemotactic agents that attract neutrophils to sites of inflammation and play a role in bronchoconstriction, making them significant in conditions like asthma. Lipoxins, on the other hand, are involved in the resolution of inflammation, promoting the clearance of inflammatory cells and tissue repair. This balance between pro-inflammatory and anti-inflammatory mediators is essential for a healthy immune response. Overall, the metabolism of arachidonic acid is vital for regulating various physiological processes, particularly in the context of inflammation and immune responses. Understanding these metabolites and their pathways is crucial for medical students, as it provides insights into how the body responds to injury and infection, as well as the potential therapeutic targets for managing inflammatory diseases and conditions. Recognizing the roles of these metabolites allows for better comprehension of common medications and their mechanisms in treating pain, inflammation, and other related disorders. Mast cells are a type of white blood cell that play a crucial role in the immune system, particularly in allergic reactions and responses to pathogens. They originate from the bone marrow and migrate to various tissues throughout the body, especially in areas close to the skin, mucosal surfaces, and blood vessels. Mast cells are characterized by their large granules filled with various bioactive substances, making them essential for mediating inflammatory responses and protecting the body from harmful agents. One of the key features of mast cells is their ability to release histamine, a potent chemical mediator involved in allergic reactions. When mast cells encounter allergens, substances that trigger allergies, they can become activated and degranulate, releasing histamine and other inflammatory mediators such as cytokines and leukotrienes. Histamine increases blood flow and vascular permeability, leading to classic allergy symptoms like redness, swelling, and itching. This rapid response helps the body to quickly deal with potential threats, but in some cases it can lead to exaggerated reactions, such as those seen in allergies and asthma. Mast cells also play a role in the innate immune response. They can detect pathogens through pattern recognition receptors, PRRs, on their surface, which recognize common features of microbes. When activated by pathogens, mast cells not only release histamine, but also produce a variety of cytokines that help recruit other immune cells to the site of infection. For example, they can attract neutrophils and eosinophils, which are important for combating infections and clearing away debris from damaged tissues. In addition to their protective roles, mast cells are involved in tissue repair and remodeling. After an injury or infection, the mediators released by mast cells promote the healing process by stimulating the proliferation of fibroblasts, cells that produce connective tissue, and the formation of new blood vessels. This healing response is crucial for restoring tissue integrity and function. However, if mast cells are overactive or persistently activated, they can contribute to chronic inflammatory conditions and tissue damage. Finally, mast cells are central players in the development of allergic diseases such as allergic rhinitis, asthma, and anaphylaxis. In these conditions, exposure to allergens leads to excessive mast cell activation and the release of mediators, resulting in severe allergic responses. Understanding mast cells and their mechanisms is essential for medical students, as it provides insights into the pathophysiology of allergic diseases and the rationale behind various treatment strategies, including antihistamines and immunotherapy. By grasping the role of mast cells in health and disease, future physicians can better manage patients with allergic and inflammatory conditions. The complement system is a crucial part of the immune system that helps the body defend against infections and plays a role in inflammation and tissue repair. It consists of a group of proteins that are primarily produced in the liver and circulate in the blood in an inactive form. When the body detects pathogens, such as bacteria or viruses, the complement system is activated through a cascade of reactions. This activation enhances the ability of antibodies and phagocytic cells to clear pathogens, promoting a rapid and effective immune response. There are three main pathways through which the complement system can be activated: the classical pathway, the lectin pathway, and the alternative pathway. The classical pathway is triggered when antibodies bind to antigens on the surface of pathogens. This binding activates the first complement protein, C1, which then activates a series of other complement proteins in a chain reaction. The lectin pathway is similar but is activated by specific carbohydrate patterns on the surface of pathogens, while the alternative pathway is activated spontaneously in the presence of certain pathogens without the need for antibodies. All three pathways converge to produce a common set of effector functions. One of the primary functions of the complement system is opsonization, which enhances phagocytosis. Opsonization occurs when complement proteins, particularly C3b, bind to the surface of pathogens, marking them for destruction by phagocytic cells such as macrophages and neutrophils. These immune cells have receptors that recognize the bound complement proteins, allowing them to engulf and destroy the pathogens more efficiently. This process is vital for clearing infections and preventing the spread of pathogens in the body. Another important function of the complement system is the formation of the membrane attack complex, MAC. When complement proteins assemble on the surface of a pathogen, they create a pore-like structure that disrupts the pathogen's cell membrane, leading to cell lysis and death. This mechanism is particularly effective against certain bacteria and helps to eliminate infections quickly. Additionally, complement activation leads to the release of anaphylatoxins, such as C3a and C5a, which promote inflammation by increasing blood vessel permeability and attracting immune cells to the site of infection. Understanding the complement system is essential for medical students, as it highlights the intricate mechanisms of the immune response and the interplay between innate and adaptive immunity. Dysregulation of the complement system can contribute to various diseases, including autoimmune disorders, where the complement system may attack the body's own tissues, and complement deficiencies, which can lead to increased susceptibility to infections. By grasping the functions and mechanisms of the complement system, future healthcare professionals can better appreciate its role in health and disease, leading to more effective management and treatment strategies for patients. Hagemann factor, also known as factor XII, is a crucial protein in the blood coagulation cascade and plays a significant role in the body's response to injury and inflammation. It is produced in the liver and circulates in an inactive form in the blood. The Hagemann factor is named after Dr. Oscar Hagemann, who discovered its role in the coagulation process. When a blood vessel is injured, Hagemann factor becomes activated, triggering a cascade of reactions that lead to blood clotting, and the initiation of the inflammatory response. The activation of Hagemann factor occurs when it comes into contact with negatively charged surfaces, such as those exposed by damaged endothelial cells or foreign materials. Once activated, Factor XII can cleave and activate several downstream proteins in both the intrinsic pathway of coagulation and the fibrinolytic system. This activation is crucial for forming a stable blood clot, which serves to prevent excessive blood loss and create a temporary barrier against pathogens that may enter through the damaged tissue. One of the key roles of activated Hagemann factor is to convert factor XV into its active form, which subsequently activates factor IX. This process is part of the intrinsic pathway of coagulation, leading to the eventual conversion of fibrinogen into fibrin, which forms the mesh-like structure of a blood clot. In addition to its role in coagulation, Hagemann factor is also involved in inflammation through the activation of the kallikrein-kinin system. This system produces bradykinin, a potent vasodilator that increases blood flow and vascular permeability, contributing to the inflammatory response. Bradykinin not only helps to recruit immune cells to the site of injury, but also plays a role in causing pain and swelling, which are characteristic features of inflammation. The interplay between Hagemann factor, the coagulation cascade, and inflammation highlights the connection between these processes and the body's overall response to injury. This multifaceted role of the Hagemann factor ensures that the body can respond efficiently to tissue damage, preventing further injury and promoting healing. Understanding the Hagemann factor and its mechanisms is essential for medical students as it sheds light on the intricate balance between coagulation and inflammation. Dysregulation of Hagemann factor activity can lead to various clinical conditions, such as bleeding disorders or inappropriate clotting, which can result in thrombosis. By recognizing the importance of Hagemann factor in both coagulation and inflammatory pathways, future healthcare professionals can better understand the complexities of hemostasis and develop effective treatment strategies for patients with related disorders. The cardinal signs of inflammation are the classic manifestations that occur in response to tissue injury or infection. These signs are essential for recognizing inflammation clinically and understanding the body's response to harmful stimuli. Traditionally, there are 4 primary cardinal signs: redness, rubor, heat, calor, swelling, tumor, and pain, dolor. In some cases, a 5th sign, loss of function, functio lysa, is also included. Each of these signs reflects specific physiological changes that occur during the inflammatory process. Redness, or rubor, occurs due to vasodilation, which is the widening of blood vessels in the affected area. This response is mediated by various chemical mediators released during inflammation, such as histamine and prostaglandins. As blood vessels dilate, more blood flows to the injured tissue, resulting in increased oxygen and nutrient delivery. This influx of blood causes the area to appear red and is often accompanied by warmth, or calor, due to the elevated blood flow. The warmth is a direct result of the increased metabolic activity and blood flow in the inflamed area. Swelling, or tumor, is another key feature of inflammation that arises from increased vascular permeability. When blood vessels become more permeable, proteins, fluids, and immune cells leak out of the bloodstream and into the surrounding tissue. This accumulation of fluid leads to edema, which contributes to the swelling associated with inflammation. The increased fluid in the tissue can cause pressure on surrounding structures, further contributing to the sensation of pain. Pain, or dolor, is a significant aspect of inflammation and serves as a protective mechanism. Several factors contribute to the sensation of pain during inflammation. The release of inflammatory mediators, such as bradykinin and prostaglandins, sensitizes nerve endings in the affected area, making them more responsive to stimuli. This heightened sensitivity results in the perception of pain, which serves to alert the individual to an injury or infection and encourages behaviors that protect the affected area. The 5th cardinal sign, loss of function, or functio lysa, refers to the impaired ability of the affected tissue or organ to perform its normal functions. This can be due to swelling, pain, and tissue damage, which collectively hinder movement or the function of the affected area. For example, inflammation in a joint can lead to reduced mobility and stiffness. Understanding these cardinal signs is crucial for medical students, as they provide important clues about the underlying inflammatory process and guide the diagnostic and therapeutic approaches in clinical practice. Recognizing these signs helps healthcare professionals assess the severity of inflammation and monitor the effectiveness of treatment strategies. Neutrophils are a type of white blood cell and are among the first responders to sites of infection or tissue injury. They play a crucial role in the innate immune response, acting as the body's primary defense against invading pathogens, particularly bacteria and fungi. When an infection or injury occurs, a series of signals are released by damaged tissues and activated immune cells, which trigger a cascade of events leading to the arrival of neutrophils at the site of inflammation. The process begins with chemotaxis, where neutrophils are attracted to the site of infection by chemical signals known as chemokines. These signals are released by damaged cells, pathogens, and other immune cells in the area. Neutrophils have specific receptors on their surface that recognize these chemokines, allowing them to migrate toward the source of the signals. This movement through the bloodstream and into the tissues is facilitated by changes in blood flow and the permeability of blood vessels, which allow neutrophils to exit the bloodstream and enter the inflamed tissue. Once neutrophils arrive at the site of infection, they perform several critical functions to combat pathogens. One of their primary roles is phagocytosis, a process in which neutrophils engulf and digest invading microorganisms. After recognizing a pathogen, neutrophils extend their cell membrane around the target, forming a phagosome. This phagosome then fuses with lysosomes, organelles containing digestive enzymes, creating a phagolysosome where the pathogen is broken down and destroyed. This process is essential for clearing infections and preventing the spread of pathogens. In addition to phagocytosis, neutrophils also release a variety of antimicrobial substances and enzymes to help combat infections. These substances include reactive oxygen species, ROS, which are highly reactive molecules that can damage and kill pathogens. Neutrophils also produce defensins, which are small proteins that can disrupt the membranes of bacteria, leading to their destruction. Furthermore, neutrophils release cytokines that help coordinate the immune response by signaling other immune cells to come to the site of infection. Another important function of neutrophils is the formation of neutrophil extracellular traps, nets. Nets are web-like structures composed of DNA and antimicrobial proteins that neutrophils can expel into the extracellular space. These traps can ensnare and immobilize pathogens, preventing their spread and facilitating their clearance by other immune cells. However, while neutrophils are essential for fighting infections, persistent or excessive neutrophil activity can lead to tissue damage and contribute to inflammatory diseases. Understanding the arrival and function of neutrophils is critical for medical students, as it provides insights into the body's immediate response to infections and the delicate balance needed to maintain health. Macrophages are a type of white blood cell that plays a crucial role in the immune system, serving as key players in both the innate and adaptive immune responses. They originate from monocytes, which are a type of precursor cell that circulates in the bloodstream. When there is an infection or tissue injury, monocytes migrate to the affected tissues, where they differentiate into macrophages. These cells are found throughout the body, including in tissues, organs, and lymph nodes, where they perform various essential functions to help protect the body against pathogens. One of the primary roles of macrophages is phagocytosis, a process in which they engulf and digest pathogens, dead cells, and debris. When macrophages encounter a foreign invader, such as a bacterium, they extend their cell membrane around the pathogen, forming a structure called a phagosome. This phagosome then fuses with lysosomes, organelles that contain digestive enzymes, to create a phagolysosome. Within this phagolysosome, the pathogen is broken down and destroyed. This ability to clear pathogens and debris is vital for maintaining tissue homeostasis and preventing infections. Macrophages also play a significant role in the inflammatory response. When they detect signs of infection or tissue damage, they release various cytokines and chemokines, signaling molecules that help coordinate the immune response. These substances recruit other immune cells to the site of infection and promote inflammation, which helps contain and eliminate pathogens. Additionally, macrophages can present antigens, pieces of the pathogens they have engulfed, to T cells, thereby linking the innate immune response with the adaptive immune response. This antigen presentation is critical for the activation of T cells, which are responsible for producing a targeted immune response against specific pathogens. Beyond their roles in phagocytosis and inflammation, macrophages are also involved in tissue repair and wound healing. After clearing pathogens and debris, macrophages secrete growth factors and cytokines that promote the proliferation of fibroblasts and endothelial cells, which are essential for tissue regeneration and repair. They help orchestrate the healing process by regulating inflammation and facilitating the transition from an inflammatory response to a healing response. This balance is crucial for ensuring proper recovery and preventing chronic inflammation. Macrophages exhibit remarkable plasticity, meaning they can adapt their functions based on the signals they receive from their environment. They can polarize into different states, commonly referred to as M1, pro-inflammatory, and M2, anti-inflammatory macrophages. M1 macrophages are typically activated in response to pathogens and promote inflammation, while M2 macrophages are more involved in tissue repair and resolving inflammation. Understanding the diverse roles and mechanisms of macrophages is essential for medical students, as it highlights their importance in health and disease, including their involvement in chronic inflammatory conditions, autoimmune diseases, and cancer. By recognizing the functions of macrophages, future healthcare professionals can better appreciate the complexities of the immune response and develop more effective treatment strategies. Chronic inflammation is a prolonged and dysregulated immune response that lasts for weeks, months, or even years. Unlike acute inflammation, which is a short-term response to injury or infection, chronic inflammation can occur when the body fails to eliminate the initial cause of inflammation, such as persistent pathogens, ongoing irritation, or autoimmune responses. This prolonged state of inflammation can lead to tissue damage, scarring, and the development of various chronic diseases, making it a significant concern in medical practice. One of the primary causes of chronic inflammation is the presence of persistent infections. Some pathogens, such as certain bacteria and viruses, can evade the immune system and remain in the body for extended periods. As the immune system continues to respond to these pathogens, it leads to ongoing inflammation. Additionally, chronic inflammatory responses can be triggered by non-infectious factors, such as exposure to irritants like tobacco smoke, pollutants, or chemicals, which can cause continuous injury to tissues and result in inflammation. Autoimmune diseases are another significant contributor to chronic inflammation. In these conditions, the immune system mistakenly targets the body's own tissues as if they were foreign invaders. This leads to an ongoing inflammatory response that can damage various organs and tissues. Diseases like rheumatoid arthritis, lupus, and multiple sclerosis are examples where chronic inflammation plays a central role in the progression of the disease, leading to pain, dysfunction, and tissue destruction. Chronic inflammation is characterized by the presence of specific immune cells, including macrophages, lymphocytes, and plasma cells, which persist in the affected tissues. These cells continuously release inflammatory mediators, such as cytokines and chemokines, which recruit more immune cells to the site of inflammation. This can create a cycle of inflammation that perpetuates tissue damage and impairs the healing process. Over time, this ongoing inflammation can lead to structural changes in tissues, such as fibrosis, scarring, and the formation of granulomas, which are clusters of immune cells that form in response to chronic irritation. The consequences of chronic inflammation can be far-reaching, contributing to the development of various diseases, including cardiovascular disease, diabetes, cancer, and neurodegenerative disorders. Understanding the mechanisms and effects of chronic inflammation is crucial for medical students, as it helps illuminate the underlying processes that contribute to these diseases. By recognizing the role of chronic inflammation in health and disease, future healthcare professionals can better diagnose, manage, and develop targeted therapies to address the underlying causes of chronic inflammatory conditions, ultimately improving patient outcomes. T lymphocytes, or T cells, are a critical component of the adaptive immune system and play a significant role in chronic inflammation. They are produced in the bone marrow and mature in the thymus, where they develop the ability to recognize specific antigens presented by other cells. In chronic inflammation, T cells become activated in response to persistent antigens, such as those from ongoing infections, autoimmune processes, or chronic irritants. Their activation and sustained presence in inflamed tissues contribute to the ongoing inflammatory response and its associated tissue damage. There are several subtypes of T cells, each with distinct functions. The main types involved in chronic inflammation are helper T cells, CD4+ T cells, and cytotoxic T cells, CD8+ T cells. Helper T cells are essential for orchestrating the immune response by releasing cytokines that activate and recruit other immune cells, including B cells and macrophages. In chronic inflammation, these helper T cells can become polarized into different subsets, such as Th1, Th2, or Th17 cells, each producing unique cytokines that can either promote or regulate inflammation. For example, Th1 cells are associated with promoting inflammation and activating macrophages, while Th2 cells can contribute to allergic responses and tissue repair. Cytotoxic T cells, on the other hand, are responsible for directly killing infected or damaged cells. In chronic inflammation, these cells can become activated and contribute to tissue damage by attacking not only infected cells, but also healthy tissues that may be mistakenly identified as harmful. This process can lead to a cycle of inflammation, where tissue damage further exacerbates the immune response, perpetuating the chronic inflammatory state. The persistence of T cells in inflamed tissues can also lead to the development of a specialized immune environment characterized by the formation of immune cell clusters known as tertiary lymphoid structures. These structures resemble lymph nodes and can develop in chronic inflammatory conditions. They serve as sites for ongoing immune activation, where T cells can continually interact with antigen-presenting cells, leading to sustained inflammation and tissue damage. This chronic immune activation can also result in fibrosis, where excessive scar tissue forms in response to ongoing inflammation, impairing the normal function of affected organs. Understanding the role of T lymphocytes in chronic inflammation is essential for medical students, as it provides insights into the mechanisms underlying various chronic diseases, such as rheumatoid arthritis, multiple sclerosis, and chronic obstructive pulmonary disease, COPD. By recognizing how T cells contribute to the inflammatory process, future healthcare professionals can better understand the importance of targeted therapies, such as immunosuppressive drugs or biologics, that aim to modulate T cell activity and reduce chronic inflammation. This knowledge can help improve patient care and outcomes in those suffering from chronic inflammatory diseases. B lymphocytes, or B cells, are a vital component of the adaptive immune system, primarily responsible for producing antibodies that help combat infections. They originate and mature in the bone marrow and play a crucial role in both the immune response to pathogens and in the processes associated with chronic inflammation. In chronic inflammatory conditions, B cells can become activated in response to persistent antigens, such as those from chronic infections, autoimmune diseases, or ongoing tissue damage, contributing to the pathophysiology of these conditions. When B cells encounter their specific antigen, they undergo a process known as activation. This activation often requires help from T helper cells, which provide essential signals through direct contact and cytokine release. Once activated, B cells proliferate and differentiate into plasma cells, which are the antibody-producing factories of the immune system. In chronic inflammation, the continuous presence of antigens can lead to an excessive or inappropriate activation of B cells, resulting in the production of antibodies that may target not only pathogens, but also the body's own tissues, contributing to autoimmune responses. In addition to producing antibodies, B cells play a role in the formation of memory cells. These memory B cells persist long after an infection has been cleared, allowing for a more rapid and robust response if the same antigen is encountered again. However, in the context of chronic inflammation, these memory B cells can perpetuate the immune response against persistent antigens, leading to ongoing inflammation and tissue damage. This cycle of activation and reactivation can result in chronic inflammatory diseases, where the immune system continues to target the body's own tissues. B cells also contribute to chronic inflammation by producing various cytokines and chemokines, which are signaling molecules that help recruit and activate other immune cells. For instance, activated B cells can release pro-inflammatory cytokines, such as IL-6 and TNF-alpha, which can enhance inflammation and influence the activity of T cells and macrophages. This interplay between B cells and other immune cells can create a feedback loop that sustains chronic inflammation, leading to further tissue damage and dysfunction. Understanding the role of B lymphocytes in chronic inflammation is essential for medical students, as it sheds light on the mechanisms underlying various chronic diseases, such as systemic lupus, erythematosus, SLE, rheumatoid arthritis, and chronic infections. By recognizing how B cells contribute to the inflammatory process, future healthcare professionals can better appreciate the potential for targeted therapies, such as monoclonal antibodies or B-cell depletion therapies aimed at modulating B-cell activity and reducing chronic inflammation. This knowledge is crucial for developing effective treatment strategies to manage patients with chronic inflammatory conditions, ultimately improving their quality of life and health outcomes. Granulomatous inflammation is a specific type of chronic inflammation characterized by the formation of granulomas, which are small, organized clusters of immune cells. This type of inflammation typically develops in response to persistent irritants or pathogens that the immune system has difficulty eliminating, such as certain bacteria, fungi, or foreign substances. Granulomas serve as a protective mechanism, attempting to isolate and contain these persistent agents to prevent further tissue damage. Understanding granulomatous inflammation is essential in identifying and managing various chronic diseases. The formation of granulomas begins when macrophages encounter a persistent pathogen or irritant that they cannot effectively phagocytose or eliminate. These macrophages become activated and undergo morphological changes, often transforming into larger cells known as epithelioid cells. Epithelioid cells are specialized macrophages that have a more prominent cytoplasm and resemble epithelial cells. They work together to surround and encapsulate the offending agent, thereby forming the core of the granuloma. In some cases, these macrophages can also fuse to form multinucleated giant cells, which are another hallmark of granulomatous inflammation. A variety of immune cells contribute to the formation and maintenance of granulomas. In addition to macrophages, T lymphocytes, particularly CD4+ T helper cells, play a crucial role in this process. When T cells recognize antigens presented by macrophages, they release cytokines, such as interferon gamma, IFNG, which further activate macrophages and promote the formation of epithelioid cells and giant cells. This interaction creates a network of immune cells that work together to contain the persistent irritant or pathogen, leading to the characteristic structure of a granuloma. Granulomas can be classified into two main types, caseating and non-caseating granulomas. Caseating granulomas, which contain a necrotic center, are often associated with infections like tuberculosis. In contrast, Non-caseating granulomas lack this necrotic feature and are commonly seen in conditions such as sarcoidosis or certain fungal infections. The distinction between these types of granulomas is important for clinicians, as it can guide diagnosis and treatment strategies in chronic inflammatory diseases. While granulomatous inflammation serves a protective function, it can also lead to tissue damage and dysfunction. The ongoing inflammation and formation of granulomas can interfere with the normal architecture and function of affected tissues and organs. In chronic conditions like tuberculosis, sarcoidosis, or Crohn's disease, the accumulation of granulomas can result in complications such as fibrosis and organ dysfunction. Understanding granulomatous inflammation is essential for medical students, as it highlights the complexities of the immune response in chronic diseases and underscores the importance of targeted therapies that can help manage these conditions and mitigate potential complications. DiGeorge syndrome, also known as 22q11.2 deletion syndrome, is a genetic disorder caused by the deletion of a small piece of chromosome 22. This condition affects multiple systems in the body and is characterized by a range of clinical features, primarily involving the immune system, heart, and facial structures. The deletion affects genes that are crucial for the development of various tissues and organs, leading to the diverse manifestations seen in individuals with this syndrome. One of the most significant aspects of DiGeorge syndrome is its impact on the immune system. Individuals with this condition often have a hypoplastic or absent thymus, which is an important organ for the development of T lymphocytes, T cells. T cells are essential for the adaptive immune response, helping the body fight infections and diseases. The lack of functional T cells can lead to increased susceptibility to infections, particularly from viruses, fungi, and certain bacteria. This immune deficiency can range from mild to severe, depending on the extent of thymus involvement. In addition to immune system issues, DiGeorge syndrome is associated with congenital heart defects. These heart problems can include conditions such as tetralogy of Fallot, ventricular septal defects, and interrupted aortic arch. The heart defects arise during embryonic development due to the disruption of normal cellular signaling processes influenced by the genes on chromosome 22. These cardiac anomalies can lead to significant health challenges and may require surgical intervention early in life. Facial abnormalities are another hallmark of DiGeorge syndrome. Individuals may exhibit characteristic features such as a cleft palate, low-set ears, a small jaw, micrognathia, and wide-set eyes, hypertelorism. These facial characteristics result from the disruption of normal craniofacial development during embryogenesis. While these features can vary widely among individuals, they are often used to help identify the syndrome in affected patients. Other potential complications associated with DiGeorge syndrome include hypoparathyroidism, which can lead to low calcium levels in the blood, hypocalcemia, and associated symptoms such as muscle cramps and seizures. There may also be learning difficulties, developmental delays, and psychiatric disorders in some individuals. Given the variability in symptoms and severity, management of DiGeorge syndrome requires a multidisciplinary approach, including immunology, cardiology, endocrinology, and developmental specialists. Understanding the mechanisms and clinical features of DiGeorge syndrome is essential for medical students, as it highlights the importance of genetic factors in health and disease, as well as the need for comprehensive care in affected individuals. Severe combined immunodeficiency, SCID, is a group of rare genetic disorders characterized by a significant deficiency in both T lymphocytes and B lymphocytes, which are essential components of the adaptive immune system. As a result, individuals with SCID are highly susceptible to infections from bacteria, viruses, and fungi, often leading to severe and recurrent illnesses. Without prompt diagnosis and treatment, SCID can be life-threatening, making it crucial for medical professionals to recognize the condition early on. The underlying cause of SCID can be attributed to mutations in various genes responsible for the development and function of immune cells. One of the most common forms of SCID is X-linked SCID, caused by a mutation in the IL-2RG gene located on the X chromosome. This gene encodes a receptor subunit that is essential for the signaling of several interleukins, which are crucial for T and B cell development. Other forms of SCID may result from mutations in different genes, such as ADA, adenosine deaminase, RAG1 or RAG2, which are involved in DNA rearrangement and lymphocyte maturation. These genetic defects hinder the production or function of lymphocytes, leading to the immunodeficiency seen in affected individuals. Because T and B cells play critical roles in the immune response, their absence leads to a severely compromised ability to fight infections. T cells are responsible for cell-mediated immunity, which includes recognizing and destroying infected cells and coordinating other immune responses. B cells produce antibodies that